So for patients with VHL disease, we look at the patient and see whether or not they end up having multiple lesions that are threatening and would require an intervention. So this would include kidney tumors that would be up to or greater than 3 centimeters, hemangioblastomas that look like they're beginning to potentially cause neurological problems, or pancreatic neuroendocrine tumors that are approaching 3 centimeters in size. And in general, if we have a patient that has only one lesion, for example, one spot in the kidney, where an intervention with an ablation or a surgery would allow them to then have a long period of time where they would not need additional interventions, we would not offer belzutifan to them. We typically are offering belzutifan to patients who have multiple lesions that look like they're going to cause problems and would result in them having multiple surgeries. So we start belzutifan on those individuals. We then follow them for the toxicities. The major toxicities include anemia, and the reason they get anemia is because erythropoietin, or EPO, is a HIF2 alpha client gene. So we're basically knocking down transcription of EPO. We, in my practice, typically are using erythropoietin stimulating agents to bring up the hemoglobin levels. The second major toxicity is hypoxia, which we don't see very often in patients with VHL disease when they're younger, but we do see it in older VHL disease patients and also in patients with advanced kidney cancer. There, what we do is we will follow. We ask every patient to get a pulse oximeter. We have them watch their oxygen levels. If it goes below 90%, we have them hold the drug. We wait till it goes above 92% and then have them lower the dose. The third side effect is the fatigue, and that is something that we manage usually with dose reduction.
I have a question. Why the belzutifan is not so good for the PGL patients?
We do see shrinkage in pheochromocytomas, and I have less experience with PGL, so I don't have an answer to that question.
Yeah, in Chinese data, is not so good, but in RCC, brain, air is so good.
So are these VHL-related PGLs? Or, yeah. So I don't know, and that's very interesting.
So my team collects the specimens for PGL, and we do some research. Why? We want to explain why the belzutifan is not so good in PGL.
So probably there might be additional mutations on top of VHL that are driving the biology of the disease.
Yeah.
Very interesting.
Yeah. 这个问题问得很好啊，因为对于晚期肾癌，现在我们有很多药物治疗，无论从 EAU 还是 AUA 指南上，对于晚期肾癌，无论是1线还是2线还是后线的治疗指南，大家已经很熟悉了。无论对于肾透明细胞癌和非透明细胞癌，大家也有很多参考的依据。但是目前我们的贝祖替凡对于肾透明细胞癌，尤其晚期的肾透明细胞癌已有的数据来说，也是非常令人振奋的。所以我个人觉得，它将在晚期肾癌中给我们开启一个新的纪元。目前指南有可能把它列为2线治疗。随着我们经验的丰富和我们的数据的证实，我想它的作用会越来越大。因为正如我刚才所言，从这次的015的中国数据来说，确实是贝祖替凡的数据非常令我们惊喜。我们观察到它的安全性贫血、乏力、缺氧，总体上呢安全性是不错的。我们需要组成 MDT 和内科大夫一起帮助这个病人呢全程治疗。所以我个人认为，这个贝祖替凡将来是我们晚期肾癌一个有力的武器。当然，联合免疫治疗是不是我们将来新的方向？贝祖替凡联合免疫治疗能不能带来更好的疗效？让我们拭目以待。我刚才和艾瑞克也在沟通，我们2家打算进一步合作，开展一些新的研究。我们希望我们的合作能给大家带来新的惊喜。
Yeah, so the approval of belzutifan in advanced renal cell carcinoma clearly is a great advance for patients with renal cell carcinoma. This study looked at individuals who had received prior therapy, either with an IO agent plus a TKI. They had to have received both. And the median number of treatments that the patients had received was 3. What we saw with that study was the objective response rate was around 23%. But the other thing that we did see was that the progressive disease as best response was 34%. So clearly some people are benefiting, but others not. If patients responded, the responses are close to 2 years, and the treatment is very well tolerated. So I see the future for belzutifan in advanced renal cell carcinoma as being a monotherapy in individuals who have received prior treatments. But the big question is whether or not belzutifan should be combined with other therapies in earlier lines of treatment. We have data from LIGHTSPARK-003 that shows that in combination with cabozantinib, there's an objective response rate of around 70% and a progression-free survival of 30 months in a predominantly favorable risk population. So maybe combination with cabozantinib is a good idea. We have a number of other studies combining belzutifan with IO therapies and IO TKIs, and we don't have information on those yet. For example, there's also a study of belzutifan plus lenvatinib compared to cabozantinib, that's LIGHTSPARK-11, and we're waiting those data. We do have a few data on belzutifan with IO therapy. There are the KeyMaker studies that are being run right now. Very small numbers, but show that belzutifan together with immune therapy does not seem to have quite the same progression-free survival as belzutifan with a TKI. So maybe there is less synergy or additivity between belzutifan plus immune therapy compared to TKIs. I think we need to keep on working very hard on understanding how to use this drug. It's clearly helpful, and which combinations are going to be best and in which disease state to use, we will find out in the next few years.